some simple suggestions that people made about improving care in the emergency, and how doable are these? First of all, here's my support for geriatric emergency nurses and specialized nurses. Geriatric emergency nurses have been quite an improvement. They work collaboratively with all RN staff in emergency and connect with the community, and they connect with the nurses on the inpatient units in hospitals. And as I said, from my point of view, they have been transformational. So some suggestions. First of all is taking the time to do a thorough assessment and screening for delirium, and questioning the caregivers regarding advanced care directives, and clearly as well, I didn't say it, but their past function. How were they functioning before they actually got into this situation? Truly using a patient-centered approach and understanding who this person is, instead of just using the words like, I do patient-centered, actually do patient-centered care. Attend to the caregivers, pay attention to them, and make them your allies and work buddies, because they want to be, from certainly what they were telling us. With staffing, considering the use of specialized nurses, trained care aides. This came up from the professionals saying, wouldn't it be nice if there were care aides in the emergency who could actually help people go to the bathroom, who could open up their food, who could actually communicate with them a little bit and calm them down when necessary. And we don't need nurses to do this, but care aides, like in long-term care facilities, could do a beautiful job if they were in emerge to do this. One-to-one protocols being defined. When do you actually need that? Amazing suggestion, have a physiotherapist to assess mobility and emerge. Why not? It would be good if we had some understanding, both in terms of deciding whether you need to admit the patient or whether the patient can go home, and what the discharge planning should look like from emerge. Do you need some recommendations about improving mobility? Now, the security guards being trained was something that came up. I didn't see this in the literature, but I heard this from the caregivers, that they felt the security guards were trained to actually stop people in their tracks. And they were very effective at doing that. When they thought that they were being violent or something, they could get their hands behind their back, they could get them on the floor, but they weren't taught to negotiate. And when I look around the hospital where I am, I don't know about in your hospitals, there's all sorts of security guards, one-to-oneing my patients with dementia, with behavior problems, and I think, couldn't we have some care aides? Couldn't we have some orderlies? You know, 30 years ago when I started in this business, we had these lovely, tall, really nice male orderlies, and they were big. And they could calm anybody down just by looking at you. And yet, I don't see the training here, and some of the staff had suggested that. Consults were available from geriatric medicine and geriatric psychiatry. I don't know if any of you are here from the north, but I did a presentation on this study in the north, and the physicians in the room laughed at me at this. They said they didn't even know what one looked like, because there weren't geriatric internists and geriatric psychiatrists in the north. We are getting more and more in the other areas, and so they may start doing consults and emerge. And all staff in emergency knowing the basic principles of good care for people with dementia. I am reminded that I went to a talk by people from Toronto a couple of years ago at the Canadian Academy of Geriatric Psychiatry, and all staff in emergence in Toronto have to be trained in the 3Ds, delirium, dementia, depression, including the physicians, in recognition and dealing with it in a short module. And I think, wouldn't it be interesting? You know, I have to do all this hand washing stuff, which is great because I want to prevent infections. But wouldn't it be great if the emergency people could actually do this kind of training too? Working on continuity of care from the community to the hospital. And I don't think discharging the patient, saying on a Thursday you're going to discharge the patient on a Friday and not connecting with the community and not connecting with the family doctor is a good discharge planning process. But I'm afraid I've seen that very often. And with my own patients who've been in the hospital, sometimes what happens is that all of a sudden they need the beds, so that I hear, first of all, I hear the patient's going to be in for 4 more days, and then a crisis has happened in the emerge, they need the beds, So the patient is discharged today, they've canceled the family meeting, there's no discharge plan, and they're home. That's it. Because they are responding, quite rightfully, to the crisis in emergency. But that patient goes home and the family doesn't even know what medications they're on, let alone anything else. So, important. Exploring options for specialized units, specialized staff, and specialized programs for patients with dementia. From my point of view, you're always going to have these people in the hospital, and I really do believe that there's literature to support aggregating them in a special area with nurses who really are interested in that kind of care and setting up programs which will actually support them. Comprehensive interdisciplinary assessments, working on elder and dementia-friendly environments, development of dementia care protocols, like maintaining a least restraint, again, the non-pharmacological approaches to management of behavior, and that is truly understanding what's behind that behavior, recognizing that it's a responsive behavior, it's not a bad behavior, that they're responding to something and that we need to know what's going on in that person's mind or their environment and try to deal with it. Using appropriate medication protocols for managing behavior. Reviewing, well, here's one that came up with the staff. Reviewing the overcapacity protocol effect on behavior and infection rates. Some of the staff felt that the overcapacity protocols were having a negative impact on the frail patients in the ward, particularly the demented patients, when there was a lot of chaos and constriction. And this one is important to me as a geriatric psychiatrist, creating meaningful activity programs so that patients that are there for more than a few days have routines, like exercise classes, walking programs, music therapy, family education programs. And if you can do nothing else, at least get them up in a chair to eat. If you can do nothing else, I really think we should be having specialized units where some of these other programs can be done because you can maximize their function. Instead of all that awful stuff that happens in the hospital, you could actually look at improving their care, improving their function. Having daily rounds, obviously, to update. Working on the smooth transitions, making education regarding dementia care a priority, and including dementia care within quality improvement processes. I hear all the time that patient satisfaction assessments in the hospitals are wonderful. And when I've done them in my own unit, they're wonderful. Patients love me, great. That's not really very helpful. What is more helpful, I think, is sitting down with the caregiver and saying, of somebody who's suffers from dementia, is saying, what happened while your loved one was here? What worked for you? What didn't work for you? And allowing them to actually give some clues. Because if it's just a form, I don't think we're getting the answers we need. I think we actually have to do one-to-one interviews to actually, in a quality improvement process, to find what's going on. So, 5 priorities for acute care. First of all, who's that person? So the person-centered approach. And again, 48.6, considering pain. Consumer or caregiver feedback. How did we do? Least restraints and assessing and managing behaviors. Here's a quote. Okay, the one I've seen the most is the behavioral stuff. People are bumping along, doing pretty good. They might even have fairly advanced dementia, but when the behavioral stuff comes up, that's what pushes people over the edge. From my experience, it's mainly been the behavioral stuff. When the caregiver is not having the capacity to deal with it and just saying, forget it, I'm done. I would hope that all of us recognize that these caregivers are truly stressed. They're not bad human beings. They're not being disloyal, unfaithful. They're stressed. And in the situation where they are really stressed, we need to support them rather than to judge them. Developing care plans for them within 48 hours, we may be able to be on the right track. I just did some presentations for psychiatry last week at VGH, and the psychiatrists, aren't the first people to think about bowels and bladders, but they need to. And we need this all through the acute care hospital, not just in the geriatric units. So this is the logo for 48.6. I'm a true believer in this, and I think that it may actually help. I know Providence is using it and VIHA has used it, but it will be a provincial program, and the expectation is that all hospitals will do some work on 48.6 within the next year and be fully implemented in 2014. So I'm going to stop there.